in that panel, we've got Josh Golden, who I've known for several years now. Josh is with Capital RX, one of our transparent PBMs, and Jeff Goldfarb with Novo Nordisk. And it was interesting, the planning of the session and how the discussion went. I've known Josh a few years. He's really passionate about the GLP-1s and the problems it causes and the solutions that are out there. So Josh and Jeff, take it away.
I'll let you kick it off. Yeah?
All right. Yeah, thanks, Chris. I appreciate it. First, thanks for having us here. Really appreciate the opportunity to talk. And what I'm going to talk to you about today may be a little bit different than some of the other sessions you've had, because I'm a pharmacist and I work for Novo Nordisk, the manufacturer of semaglutide. Semaglutide is the generic name for Ozempic and Wegovy. So you may hear those interchanged in some of my slides because the way the publications are. But I'm going to give you a little bit of science today. So obviously GLP-1s have changed the way we treat type 2 diabetes and obesity, right? And the cost pressures that have come along with that are making benefit design challenging. So Josh is going to talk about utilization management and strategies in just a minute to address the inefficiencies and waste. But I think it's important to ground any discussions we have around benefit design in the science, right? In the clinical value, as well as the potential cost offsets generated by that clinical value. So there's over 200 downstream consequences of obesity. There's a handful listed on the slide behind me. These can be clinically devastating, they can be very expensive, and it's not just about weight, right? I think the focus has been about weight for a long time, but the things that we're really trying to prevent are on the slide that you can see here. We pay for obesity either way. You either pay for prevention of these things or you pay for the consequences downstream. And from a clinical perspective, that's an easy answer. In medicine, we're going to try to prevent these things, but when you throw in the economic pressures, then that discussion gets a lot more complicated. So I'm going to show you today 3 studies that are real world in nature. Now that the drug's been out for over 4 years, for Wegovy specifically, we have access to claims data. When we first launched these drugs, everybody wanted to know, when are we going to see ROI? When are we going to get our money back on these medicines? And we couldn't answer that. We had modeling that showed maybe 3 years, maybe 5 years. But now we have claims data. We can actually show real world what's happened. I'll share those 3 studies with you. They're similar in design. I'll describe the design here, and then I'll show you the results. So they looked at claims data over 1 year. So as I said, historically we thought maybe 3 years, maybe 5 years, you'd see some return. But 1 year was the design of the studies, and this was done, at risk really, because that's a very difficult endpoint to show clinical or medical cost offsets within a year. But it's also relevant. Say you're an employer that has a lot of turnover, so it's good to see what should we expect within a year. These studies do not include pharmacy costs, and that was intentional because costs differ. And as you see in the headlines, the cost is changing every day, it seems like. So you're able to plug in your own cost when you see these medical cost decreases and determine for yourself whether or not it's worth it. The other thing is the patients in these studies were adherent, with a proportion of days covered at 80%. So most of these patients were really good at taking their medication. So those are some limitations, the design of the studies, and they're all pretty similar, looking at 3 different populations. The first one I'll show you, called the SEEK study, S-E-E-K. And by the way, we're going to go through this very quickly, so catch me over the break if you want. I can have these emailed to you or whatever. They're all published within the past few months. The SEEK study looked at a population of overweight and obese patients, and they looked at an index date and then 12 months after starting the medication. And they compared the Wegovy users to non-users. And these were matched groups, so very similar groups. And what they found was that within the first 12 months, Wegovy users spent over $1,500 less in medical spend than they did the year prior. The non-users spent over $1,700 more, for a difference of over $3,300 within the first year. So pretty promising. This is just for your obesity and overweight population with comorbidities. I'm talking about the bar graph on the left. We don't have enough time to dive into details, but let me know if you want to go in at the break. The next study I'll show you is the SHINE ASCVD study. So ASCVD stands for atherosclerotic cardiovascular disease. So these are patients with overweight or obesity with established cardiovascular disease. And comparing Wegovy users to non-users, the Wegovy users spent over $4,600 less in medical spend within the first year compared to non-users. Very similar study called the SHINE Heart Failure Study, HF standing for heart failure. In this population, $8,500 less spent in Wegovy users compared to non-users. So that's, promising information, within a year. I think, most people would expect this to kind of compound over time. These studies will continue, so we'll see what happens over time. But, our session is called Sustainable Benefit. This is the sustainable benefit, right? The clinical outcomes that we're seeing here. So, benefit design, it's complex, right? The clinical story is easy. Like we know it works, and these indications continue to grow. We get getting more and more evidence. But the coverage decision should really be rooted in the science, which should support initiation and adherence to these medications. And when these decisions are made, things like this should be taken into consideration. And many times it's not. Many times we just see the pharmacy costs go up. We don't really look at the medical costs coming down, as well as other things like productivity, absenteeism, workers' comp, meds that you can stop in other places, procedures you might avoid. So lots of different ways you can go. But the medical cost is one thing that we can pretty easily measure, and we're expecting more data as we go. So we've learned a lot since Wegovy's launch 4 years ago. But believe it or not, we're still in the early stages. We've had some recent indications added, a liver disease indication added a few months ago, and they're going to continue to grow. We also have oral formulations coming very soon. We have higher doses with more efficacy coming very soon. We have better tolerability coming very soon. So the discussion's really just getting started. So unfortunately, I know you're talking about GLP-1s a lot, but it's not going away. We have more to come. So I'll hand it off to Josh now. I appreciate your attention, and he's going to talk about some practical strategies to manage utilization.
And feel free to chime in. Okay. I know you're limited on what you can, sort of what and how you can comment, but I wanted to give folks a sense of what we're seeing plan sponsors do to manage this unprecedented explosion of cost and utilization. We should all take a moment to appreciate this is a once-in-a-lifetime pharmacological event. There has never in the history of pharmacotherapy been an explosion of cost and utilization on a branded product with an addressable market that falls somewhere between a third and a half of the United States, right? Most of which is shouldered is being shouldered by plan sponsors. So a lot of what we do in our role, we're obviously a fully aligned PBM solution, and we feel that we're in a really critical role, as is any PBM, in managing the tide of cost and utilization here to create a sustainable infrastructure. I don't think anyone in this room at this point is doubting the clinical value of these drugs, and I think there's enough of a consensus across employers that obesity is a disease that should be treated, that there are clear pathways to ROI here. So I don't think we really are at a point where we're still trying to convince employers that this should be covered. It's more a question of how the heck do we do it and not bankrupt the plan, right? And not run the plan entirely off the rails financially. The PBM role is really critical here. I always like to start any discussion about management of a benefit and the PBM's role in management with a reminder that PBMs make money in different ways. And some large established PBMs have a very diversified revenue system that they rely on for profitability. Some PBMs are like Capital RX, pure admin fee, fully disclosed, everything above board, no profit from the dispensing volume or price of drugs. So nothing tied to spread or some of the other issues that have been discussed in previous panels. But there's a lot of PBMs out there that rely on these ancillary revenue streams, these other sort of opaque, hidden revenue streams. And that creates a conflict of interest that plays out on a day-to-day basis. I like to say that when you hire a PBM, you're deputizing them to make 1,000 tiny decisions every day on behalf of your plan. You're the fiduciary, but you're kind of handing over the steering wheel of the plan. And the devil really is in the details here. I want to give you an example. We get access to a lot of data from traditional PBMs, and that's because we're invited to a lot of RFPs, and we get access to the data for those incumbent clients. And the things we find relative to GLP-1s right now are really alarming and worth discussing in a really candid manner. The first I want to talk about is refill cadence, because this is really seems like a benign sort of minutia of plan setup, but the impact can be substantial here. What you're looking at here is a chart showing a cadence of refills for a single patient on Ozempic over the course of a year or so, right? And these are fills being dispensed from the mail order pharmacy at 90 days, or I think it's 80, ends up being 86 days because it's, as you know, weekly therapy. So what you're seeing here in dark blue is each subsequent fill. The light blue portion is the overlapping portion. So that's an early dispensing of the next 90-day fill. The first one comes 21 days early, right? You see that first light blue bar. That actually is fine. Most of my clinicians in my company would say, all good. Members need to have an extra supply on hand in case there's an ice storm in Houston or another hurricane or something like that. But what about the next fill at 42 days early? This is an actual case from data we saw in an RFP. 21 days on the next fill. The next one cut it a little close. But by the end of the year, we're looking at an excess dispensing of over 3 months of supply for a single patient for a GLP-1. At a cost to the plan, this is extra cost. So this is cost for a drug that is sitting in a refrigerator somewhere, not even in the patient's body, at about $4,000 in pure waste. So one of 2 or 3 things is happening with this patient. One, they're taking this and giving it to their cousin for microdosing, and I can tell you that is happening widespread. Number 2, they don't end up using it because at the end of the year, they decide, well, I don't like the side effects, and they flush it down the toilet. Or 3, they're stockpiling it, leaving your benefit plan, and then using it when they're working for some next employer, and you're the one stuck with the bill. So these are easy problems to solve. Capital RX has a look back around supply on hand and our refill too soon logic, and the pharmacy doesn't control this. The PBM does. I want to remind folks, the pharmacy's trying to dispense as early as they can, and they always will. That's the nature of a profit-seeking pharmacy. But the PBM has the ability to push those refills out, to deny the claim and say, no, you got to wait until the member has exhausted a reasonable amount of their inventory on hand. So this is, in this example, just by switching to a more rational refill too soon protocol, you're looking at savings north of $3,500 on a single patient. Now take that and multiply that by every patient getting a mail order prescription for GLP-1s. We didn't even get to the fact that this doesn't make sense to begin with. The fact that a patient is starting out on a GLP-1 at 90-day dispense, which makes no sense at all on a disease state, on a therapeutic class that has a discontinuation rate in year 1 somewhere around 50%?
50%,
yeah.
Similar to other chronic diseases. Yeah.
Which is not to say don't dispense the drug, but if that discontinuation happens in week 1, 2, 3 when side effects are first experienced, and that patient is sitting on 90 days of supply, you've just flushed 2.5 months of supply. Why not limit those initial fills to 28 days? So this is the minutia where plan cost or plan savings takes shape. And unfortunately, your PBM, if they own a pharmacy that's dispensing this, if they have a motive to dispense as much as possible, it falls on the fiduciary. It falls on the plan sponsor to pay attention to this minutia. And I'll run through a couple of other examples that we're seeing a big swing in outcomes in terms of cost containment here. Some of these, thankfully, Janae and from Houston Methodist did a great job of addressing a number of these, so I can actually cut to the chase and skip around a little bit. Obviously, she mentioned coverage rules around covering certain disease states and limiting access on other disease states, et cetera. I want to call out a couple here, and then if we have time, I'm happy to answer questions about ones that maybe I don't touch on. Prior authorization, right? I can tell you how many employers I have talked to have said, yeah, we're covering for weight loss, but I've got PA on. Or we're covering for diabetes only, and don't worry, we've got PA on to make sure that there's no weight loss utilization. And what I have to remind employers is that there are massive differences when you get into the details of PA criteria and how they are administered and enforced. I can tell you that our research indicates that a single variable on PA, whether you require evidence and documentation or whether you allow the doctor to attest to a result or a condition, attestation versus documentation has a swing of about 15 to 20% in PA approval rate, which means that if you just ask the doc to provide some evidence, 20% of docs can't even do that on a prescription for a GLP-1 that they're prescribing to a patient. So again, examples there. Another consideration on prior authorization is auto-decisioning, which we're seeing a lot of. And the most common auto-decisioning protocol that I'm seeing is look back for diabetes med. Have they had a diabetes med in the last year, right? Metformin, something of the like. If so, let's call it a diabetic and move on. Here's what the online docs have determined, and a lot of in-person docs as well. Well, if I want to give my patient a GLP-1, here's what I'm going to do. I'm going to give them metformin, right? Whether they have diabetes or not, let's give it to them. And then come see me in 6 weeks, and I'll give you the GLP-1 prescription. And trust me, it'll sail right through. And so docs have figured out how to navigate through these, how to maneuver through these PA loopholes to get even a non-diabetic patient access under a plan that only covers this product for diabetes. Another one I want to mention is intelligent DUR, or drug utilization review. And you probably presume your PBM is kind of keeping track of stuff, making sure that a patient's not having inappropriate utilization here. But you would be surprised at how many data sets we get from traditional PBMs that show concurrent use of multiple GLP-1s. And what ended up happening was the PBM had the quantity limit and duration limit protocols set at the product level, not the class level, which means that a patient could get access to multiple GLP-1s, could stagger them, and what you see there is stockpiling, what you see there is diversion to friends and family, or even black market sale of the product. This product does have a street value, I should mention that. So again, just make sure, easy questions to ask your PBM, is DUR set at the class level, QL, quantity limit, duration limit, is that set at the class level to prevent concurrent utilization of multiple GLP-1s? And also, are you looking out for concurrent redundant utilization of GLP-1s and a DPP-4 inhibitor, right? Which is, there's just no clinical rationale for prescribing both medications. It's waste. There's one more I want to mention, custom cost share strategy. You're going to bristle a little at this, and sorry, but I gotta poke the bear a little bit. Look, there are a lot of employers now that are saying, I want to cover this, but I have to have some skin in the game with the employee. I want the employee to know that this is an investment and to be part of the investment so that they have a strong motivation to make sure that this is successful, that we're not just both flushing money down the toilet. But what most employers don't often take into consideration is that the copay card value for these programs often covers the entirety of the patient's copay. So even though it looks like a $100 copay is asking the patient to make a personal investment in their therapy, the reality is that patient is paying $0, possibly $5, maybe $15 in actual out-of-pocket. The answer is out there. Novo, Lilly, these manufacturers publish the rules of their copay card programs on the web. They are basically giving you a guide as to what you can reasonably charge a patient that is a discount that the manufacturer is willing to pick up on a monthly basis as an extra offset to cost share. Any plan sponsor that is charging less than what that copay card is set at, I guess I wonder why that plan sponsor is leaving money on the table. And so these are just sort of some minutia that examples of minutia that you really need to think about as a plan sponsor. It's an extra burden that maybe you didn't have under some other disease states or other pharmacotherapies. We got about 7 minutes. I'll highlight maybe one or two more and also mention that there are a couple of cost containment strategies that aren't even on this because I consider them gray area strategies. One is international sourcing of GLP-1s and other branded manufacturer products. I will say that the law seems pretty clear on this, and so we as an organization have a fairly conservative stance on this, but we are aware of other third parties that are plugging in here trying to leverage that. I would say proceed with caution. We're talking about international shipments that can be delayed, that are potentially subject to volatile tariffs, right? And so this is a really uncertain landscape, not something necessarily that we are supportive of. The other is compounding, which has already been mentioned. I want to be clear, compounding in and of itself is not illegal or against the rules, but there is a very specific rule set, regulatory rule set around when and how products like GLP-1s can be compounded. While there was a period of shortage where, for both manufacturers, where compounding was deemed clinically necessary to fill some therapy gaps, At this point, we're seeing a lot of gray area, opportunistic maneuvering going on among compounding pharmacies that causes us some concern. And we leave it to the discretion of the plan sponsor what they want to do, but I would say proceed with caution on some of those gray area strategies where there may be regulatory implications, even for the plan sponsor. I guess I'll pause here. I've got some comments on others, but I don't want to shoot in the dark. Do folks have items here or others that they want to talk about?
Ted?
Hey, thanks a lot. But great topic.
Yeah.
Jeff, thanks for taking the stage. Really appreciate it. So I have a very simple question. When will employer health plans be able to access direct consumer pricing in a way we can integrate with our benefits?
So I don't have an answer for that yet, but there's a lot of developments. And Cecilia has, right there is our account manager. She probably has more information about that than I do, but I think the answer is to be determined, TBD. It's coming, but we don't have an answer.
I talked with Cecilia yesterday, and it sounds like, I don't want to paraphrasing, you don't have that answer right now either.
Correct. I mean, it's all in work is in progress. The company is having these discussions with the vendors as we speak. So just hang tight.
Well, no, I appreciate it. We had a novel plan design where we were charging a high copay, and when we switched PBMs, it was disallowed.
Huh.
And now we're proceeding without rebates from either manufacturer because we can't charge the copay that we think we should be able to. So it's hard. Creativity is not necessarily rewarded in the PBM space.
Yeah.
And so we would like to see, I'm trying to speak on behalf of the coalition and all the employers in the room that we need a break. We need a break. These are great drugs, but there was no ROI in your slides when you do take into account the cost of prescription drugs.
And to be honest, the constraints that are often placed on employers with regard to rebate contracts. And I want to acknowledge that because it's a very real, dynamic situation, but it is a real set of constraints that are changing day to day. Examples are, Janae at Houston Methodist mentioned limited prescriber networks. There was a period of time where both manufacturers were sort of suggesting, now if you try to limit the prescribing base here, you're not getting a rebate. Or if you raise the BMI above a certain level because you feel that it should be higher in order to focus your investment on those that need it most, you're not getting a rebate. Or if you require attestation on a PA instead of if you require documentation instead of just simple attestation, you're not getting a rebate. I think that that dynamic is shifting. I think the GLP-1 manufacturers largely understand that a balance needs to be struck, and we're hearing a lot more about collaboration there, striking that balance properly. But it's difficult, opaque, and ever-changing.
Yeah. Christine.
Yeah, I wanted to address that specifically. I think it's interesting. There's this ongoing debate on prior authorizations. Should we have them in place or not? Some states are looking at removing them because they're viewed as a rebate-driving strategy. But then when an employer actually wants to put a prior authorization in place to actually make sure that they're being a fiduciary, which is what they're obligated to do, I do not understand, and I'd like to hear from Novo specifically, why when we're trying to just validate what the FDA label has, which are two things, on the diabetic one, verifying that they are truly a diabetic, which requires 2 A1C tests, not just one, and also on the obesity medicine that they're engaged in lifestyle changes, which is also a part of the FDA label. Why, when they're just trying to do simple clinical management, do we forego the usage of rebates? But then when on specialty drugs, if we actually, when we're trying to encourage maybe to get more rebates, we're hearing complaints about putting prior authorizations on things. So it feels very contradictory.
So I think that question is for someone far up the food chain from me, unfortunately. I'm not involved in the contracting, but yes, I hear that often. So you're not alone. But I do feel like the landscape is changing, and there are more, flexibility coming. Cecilia, any? Is that accurate?
Yeah. This is dynamic. Look, we need to acknowledge what rebates are. They are a payment system for access to medications, right? For access to populations to offer medications and promote medications. They are not a guaranteed discount that everyone gets. They're a discount that's variable, that's based on the access that's provided. And if protocols, PA criteria, et cetera, limit access, this is not the only class where this happens. There's potential impact. I think it's just it's an economy that exists. It's this weird microeconomy within our supply chain that's highly problematic. And, I will say a couple things are changing here specific to GLP-1s. We got a lot of scrutiny on cash price right now, courtesy of the Trump administration and some of the negotiations that are going on there. A public cash price that is much lower than what is being charged on benefit plans is problematic for everyone and generally puts downward pressure on upfront point of sale cost and tends to shift rebate value to point of sale discount. And so it's likely that is what we are going to see happen here. That's what I think a lot of us are hoping for, so that we gain a little more price transparency and push that value up front where the member can receive some of it as well.
I always want to have employers have a voice, Maddie Duncan, with Frost Bank.
So one big issue that we're having is that the manufacturer coupons aren't trackable with our PBM, and so our employees are getting credited the full cost of the drug to their deductible when they've only paid $25 or whatever. There's no solution with our PBM. Curious if Capital RX has a solution to track that, but that's a huge cost driver for us.
Yeah, and this happens in specialty drugs in particular a lot, where specialty couponing can help someone hopscotch right through the deductible and even through the max out of pocket. They do have a fix on that one, that's correct. Why don't we talk after this? Yeah.
Okay, let's see here. I have a quick question. On the medical side, you showed that slide that showed decrease in cost by Wegovy users, increase in costs for not. Have you broken down what those costs are? They'll decrease. What are the categories where those who are using it are not spending it, and those who are not using it are seeing an increase in spending?
For all three of those studies, mostly driven by decrease in hospitalizations.
Yeah.
It's hospitalization.
Yep, and that aligns with all the clinical trials that show fewer heart attacks, less kidney disease, less liver disease, things that put you in the hospital.
That makes sense. I did see there was really not a difference in the ER utilization.
Right, ER not that much, and even outpatient not that much, but hospitalizations cut in half, for some of these populations.
Well, to the credit to the therapy itself, which is nothing short of a miracle therapy, there are ripple effect benefits on things like depression, anxiety, alcohol use, things that likely weren't contemplated in these narrow focus studies.
I was going to ask about, again, some of those clinical, but
right.
So
and those are things that, part of the cost offsets we can't even measure.
It's almost impossible to quantify.
Right.
Totally get it. Totally get it.
But it's being studied in this next generation of obesity medicines, where I think there's a lot more focus on things like that.
Yeah.
So we'll have a lot
Any
more.
thoughts on potential uptake or shift to the oral therapies as those are introduced to market from a scientific standpoint? I keep hearing there's this. I look at these studies. I'm very, very nerdy and curious about this, but up to 30% of the U.S. is needle averse or needle phobic, right? So how many people are GLP-1 curious that have sat on the sidelines because they're not comfortable injecting themselves? And are we likely to see a massive uptick in utilization? What are you guys thinking about that?
So the market research I've seen is 41% would consider an oral over an injectable, even though the injectables are once weekly, very well tolerated.
But some of those are already taking.
Right, they're already right. So I don't think we're going to see. This is just me talking. I don't think we have data on this. We'll know, within a
couple months.
Yeah, well, within, but by the end of this month.
Yeah.
I don't think we're going to see a lot of people switching from injectable to oral, but new starts, I think that might be where it is. But the data is compelling, though. Yeah.
All right, thank you.
Thanks, everyone.
Thank you.